Hi dear students, welcome back to my video lecture. This is Dr. Wilma. This video lecture is on phenylketonuria, which is an important metabolic defect in amino acid metabolism because it is relatively common and responds to dietary treatment. At the end of this video lecture, I expect you to know the biochemical basis, clinical features, laboratory investigations and treatment of phenylketonuria. Also, a case scenario will be explained to you so that you should be able to interpret and mention the probable diagnosis. Phenylalanine is an aromatic amino acid which consists of phenyl ring or the benzene ring with alanine. It is also an essential amino acid which cannot be synthesized within the body. It is both glucogenic as well as ketogenic. Let us recapitulate in a normal condition what will be the fate of phenylalanine. The catabolism of phenylalanine takes place in the liver. Here, the phenylalanine gets converted into tyrosine, for which you require the enzyme phenylalanine hydroxylase. Phenylalanine hydroxylase utilizes a molecule of oxygen where an atom of molecular oxygen gets incorporated into the phenylalanine to form the para-hydroxy phenylalanine. That means at the para position hydroxyl group is formed. So that the para-hydroxy phenylalanine is nothing but the tyrosine is obtained from the phenylalanine in presence of the enzyme phenylalanine hydroxylase, for which you require biopterin, which is a coenzyme. The active form of biopterin is tetrahydrobiopterin, which accepts an atom of the molecule of oxygen, so that tetrahydrobiopterin gets oxidized to dihydrobiopterin and there is a release of water molecule. So, out of two atoms of oxygen, one gets incorporated into the phenylalanine, the other one gets converted into water. The dihydrobiopterin gets converted into tetrahydrobiopterin, so that there is a regeneration of tetrahydrobiopterin in presence of the coenzyme NADPH and the enzyme dihydrobiopterin reductase. Before going to the details of phenylketonuria, which is one of the inborn errors of amino acid metabolism, let us know the brief history of inborn errors of metabolism. It was Sir Archibald Garrett in 1908 introduced inborn errors of metabolism, otherwise known as inherited metabolic disorders or inborn or congenital metabolic disorders. The Garrett's tetrad has got the four conditions, that is alketonuria, albinism, pentosuria and cystinuria. In a normal condition, when the gene is expressed, it leads to synthesis of a normal protein, which is nothing but there is a synthesis of a normal enzyme, because all enzymes are proteins except ribozyme. So when this enzyme acts on the specific substrate, that substrate gets converted into product. So there is a normal metabolic pathway taking place without any harmful effect. But in case of inborn errors of metabolism, there is a defective gene which is synthesizing a defective protein, so that there is a defective enzyme which cannot act on the substrate on which it was supposed to act, and the substrate cannot get converted into a product. So there is no normal metabolic pathway taking place, so that there is accumulation of the substrate leading to harmful effect, or it can get converted into other products by entering into the alternative pathway. we are going to discuss about phenylketonuria, which is an important inborn errors of amino acid metabolism, which is relatively common and which responds to dietary treatment. Absence or deficiency of phenylalanine hydroxylase leads to the most common clinically encountered inborn errors of amino acid metabolism, which is known as phenylketonuria. Here is a poem written by a father of a baby diagnosed as phenylketonuria. At the tender age of 3 weeks, the doctor said, "I am sorry to say he's not right. He has got a genetic disorder." He said, "Phenylketonuria was the name of my plight. Not another sound did I hear, my babe, playing softly against my heartbeat, pounding in my ears, my vision blurred madly behind my tears." How could this be? I asked myself. You are perfect in every way. 2 beautiful eyes, 10 fingers, 10 toes, 1 nose. How dare the doc say there is something wrong with my son? How dare he say nothing can be done? So don't you fear, my little dear. Mom is here and we shall overcome this disorder, this phenylketonuria. Here is the saga or the long history of phenylketonuria. In 1934, Dr. Folling, he noticed hyperphenylalaninemia associated with mental retardation. He called it as phenylketonuria. In 1937, Dr. George Jervis identified a mutated enzyme as the cause for phenylketonuria. In 1951, Professor Bickel developed the first effective treatment of phenylketonuria. The history of phenylketonuria continues as follows. In 1958, Dr. Robert Guthrie developed the Guthrie's test. In 1966, the Guthrie test becomes a standard medical practice across the world. In 1992, Dr. Wu identified the gene for the mutated enzyme which causes phenylketonuria. In 1993, a medical research council report recommends that all the phenylketonuria patients should maintain a low protein diet for lifetime. Phenylketonuria is known to be an autosomal recessive genetic disorder. This means both the parents must have at least one mutated allele of the phenylalanine hydroxylase gene. As we see in this picture, both the parents are having the mutated alleles as indicated as the cross mark. Therefore, the child must inherit both mutated alleles, one from each parent. As we see in this picture, the fourth child has obtained both the mutated alleles, one from each parent. But in the first child, there are no mutated alleles, so the child is not a carrier as well as not a suffering patient with phenylketonuria. The second and third child, though they have obtained a mutated allele, but both the alleles are not mutated. So they are just the carriers, not the suffering from the condition. But the fourth one has obtained both the mutated alleles, hence the child is suffering with phenylketonuria. A child from 2 parents with phenylketonuria will inherit 2 mutated alleles every time. Therefore, the phenylketonuria appears. Phenylketonuria is also known as Folling's disease because phenylketonuria was discovered by the physician Dr. Folling. The frequency of phenylketonuria in India is 1 in 25,000 births. Most cases of phenylketonuria are due to phenylalanine hydroxylase gene defect. The gene spans 90 kb on chromosome 12q23.2 and contains 13 exons. Normally, phenylalanine is converted into tyrosine in presence of the enzyme phenylalanine hydroxylase, so that in presence of the tetrahydrobacterin and a molecule of oxygen, phenylalanine is converted into tyrosine. But in most of the cases of phenylketonuria, phenylalanine hydroxylase enzyme is deficient or defective. Hence, phenylalanine cannot be converted into tyrosine. But there are other causes for phenylketonuria also. It may be due to defect in dihydrobiopterin reductase, the enzyme required to regenerate tetrahydrobiopterin from dihydrobiopterin, or may be defect in dihydrobiopterin synthesis. The defect or the deficiency of phenylalanine hydroxylase leads to a classic or the type 1 phenylketonuria. If there is a defect in dihydrobiopterin reductase, which is required for the regeneration of tetrahydrobiopterin, leads to type 2 and type 3 types of phenylketonuria, and defect in enzymes which are utilized for the synthesis of tetrahydrobiopterin from GTP leads to type 4 and type 5 phenylketonuria. Because tetrahydrobiopterin is required for hydroxylation of tyrosine as well as tryptophan. Hence, synthesis of catecholamines from tyrosine and synthesis of serotonin and melatonin from tryptophan are also affected. Therefore, these variant forms, that is type 2, 3, 4 and 5, results in more severe clinical manifestations. When the main pathway is blocked for the conversion of phenylalanine to tyrosine, the phenylalanine concentration increases in the blood. The normal level of phenylalanine in blood is 1 mg per deciliter. Hence, the increased concentration of phenylalanine enters into the minor pathway, so that this minor pathway becomes the major metabolic fate for the accumulated amino acid, that is phenylalanine. So the phenylalanine gets converted into phenylpyruvate by transamination reaction, for which alpha ketoglutarate is required, and the pyridoxal phosphate transaminase enzyme is required. So this phenylpyruvate is excreted in the urine and accounts for the name phenylketonuria. In addition to phenylpyruvate, the phenylpyruvate gets converted into phenyl acetate by decarboxylation, and further conjugation with glutamine, it is excreted as phenylacetylglutamine. Otherwise, it can also undergo reduction to form phenyllactate. So these are the metabolites which are excreted in the urine in case of phenylketonuria. So these are the alternate pathway for the phenylalanine when the main pathway is blocked. Phenylketonuria is not evident at birth, and clinical manifestations appear a few days or weeks later. The phenylalanine is present in high concentrations, maybe 10 times more than the normal, in tissues, plasma and urine. So this phenylalanine enters into the minor pathway and gets converted into phenyllactate, phenylacetate, phenylpyruvate, which are not normally produced in significant amounts in the presence of functional phenylalanine hydroxylase. But in case of phenylketonuria, these are elevated. These metabolites gives urine, a sweat and breath a characteristic musty or mousy odor. Also, we can find eczematous dermatitis and delay in development as well as the stunted growth. Patients with untreated phenylketonuria may show hypopigmentation of hair and skin. The hydroxylation of tyrosine by copper-containing enzyme tyrosinase is required for the first step in the formation of pigment melanin. In case of phenylketonuria, there is inhibition of this enzyme tyrosinase by increased level of phenylalanine, which leads to impaired melanin synthesis in the melanocytes and hypopigmentation of hair and skin. The most important clinical presentation is mental retardation. So the child develops mental retardation with IQ values typically between 25 and 50. The patient with untreated phenylketonuria typically shows symptoms of intellectual disability by age of 1 year and rarely achieves an intelligence quotient greater than 50. So for every 100 micromole per liter increase of phenylalanine, there is up to 4 points drop of intelligence quotient. The other central nervous system manifestations are microcephaly, irreversible neurological impairment, epilepsy, tremors, agitation, autism, decreased concentration, movement disorders. Since tetrahydrobiopterin is also required for tryptophan catabolism, we can find low serotonin levels and lack of synthesis of neurotransmitter due to the deficiency of tyrosine, because tyrosine is synthesized from phenylalanine, and if tetrahydrobiopterin is defective, that means either the regeneration of tetrahydrobiopterin or synthesis of tetrahydrobiopterin from GTP, there will be decrease in the catecholamine formation. So we can find lack of synthesis of neurotransmitters. The biochemical investigations for phenylketonuria are the estimation of blood phenylalanine and the detection of presence of phenylalanine in the blood in a higher concentration can be done by chromatography or by tandem mass spectroscopy. Tandem mass spectroscopy is more reliable than the chromatography, and the presence of phenylpyruvate in the urine can be detected by the ferric chloride test. Here, a drop of ferric chloride is added to the urine of a newborn baby. If there is a transient appearance of olive green or a blue-green color, then it indicates that there is a presence of phenylketones in the urine. Then prenatal diagnosis with the DNA probes can be detected to verify or they check the presence of phenylalanine hydroxylase defect. The rapid screening test is the Guthrie's test, which was developed in 1961 by Robert Guthrie. Here, certain strains of Bacillus subtilis needs phenylalanine for its growth. Bacteria cannot grow in a medium which do not contain the phenylalanine. Based on this, Guthrie's test was developed. The bacillus was inoculated into the medium so that in the medium the Bacillus subtilis will remain and it will not start growing. So once the sample or the blood sample is added to the medium, if the phenylalanine is present, the bacteria will start growing. So that here it indicates that bacterial growth is proportional to the phenylalanine content in the patient's blood sample. Early diagnosis is a must in case of phenylketonuria because about 5 units of IQ are lost for each 10 weeks delay in starting the treatment. Hence, after the diagnosis, a strictly controlled phenylalanine free diet up to first decade of life is very important. From this picture, choose the foods which are closest to the bullseye like fruits, vegetables, low protein breads and pastas. Here we get the clear picture of the foods with high phenylalanine content and foods with low phenylalanine content. The high phenylalanine foods are like fish, meat, dairy products, nuts, eggs, etc. And the low phenylalanine foods are most of the vegetables, most of the fruits, and sugars, and special breads without the protein. Here we have a list of high phenylalanine foods on the left hand side with fish, meat, dairy products and eggs, etc. And on the right hand side we have low phenylalanine foods like vegetables, fruits and then breads with low protein content, etc. After the first decade of life, in case of phenylketonuric babies, the phenylalanine should be supplemented or small doses of phenylalanine must be supplied because phenylalanine is an essential amino acid. Other than the dietary control of phenylalanine, diet rich in tyrosine can be tried if it is not a variant form of phenylketonuria and enzyme replacement therapy. The drug like sapropterin dihydrochloride, which is a form of tetrahydrobiopterin, which breaks down phenylalanine blood, will be very useful in case of variant form of phenylketonuria. Apart from the diet, the clinical trials which are still going on for the treatment of phenylketonuria are gene replacement therapy and gene augmentation therapy. Here we have an additional information about phenylketonuria, that is maternal phenylketonuria. If women with phenylketonuria who are not on a low phenylalanine diet become pregnant, the offsprings are affected with maternal phenylketonuria syndrome. In this case, high blood phenylalanine levels are seen in the mother, which leads to microcephaly and congenital heart abnormalities in the fetus because phenylalanine is a teratogen. These developmental responses to high phenylalanine occur during the first months of pregnancy. Hence, dietary control of blood phenylalanine must begin prior to the conception and it must be continued throughout the pregnancy. Here is a case scenario of a 10 months old girl who was brought to the hospital to investigate her mental retardation. She had fair skin, light colored hair, and blue eyes. Her mother noticed a mousy odor of urine, interpreted the following laboratory findings, and mentioned the probable diagnosis. The laboratory findings revealed the phenylalanine concentration in the plasma of 30 milligrams per deciliter and phenylpyruvate 6.2 grams per day excreted in the urine, phenylactate 4.2 grams per day excreted in the urine, and phenylacetylglutamine 2 grams per day excreted in the urine. Now, to interpret the laboratory findings, there is accumulation of phenylalanine because the normal phenylalanine concentration in the plasma is 1 milligrams per deciliter. But in this case, there is accumulation of phenylalanine to 30 milligrams per deciliter. So, increased phenylalanine concentration in the blood leads to the most important clinical manifestation, that is mental retardation. As we have seen, that is the first complaint of the mother about the baby. And baby also had fair skin and light color hair and blue eyes due to increased phenylalanine concentration, which is causing competitive inhibition of the enzyme tyrosinase, which is a copper dependent enzyme which converts tyrosine to melanin in melanocytes, so that here increased concentration of phenylalanine causes competitive inhibition of the enzyme tyrosinase. Hence, conversion of tyrosine to melanin is blocked, which is leading to fair skin and light colored hair and blue eyes. The major metabolic pathway phenylalanine is blocked here. Hence, it has entered the minor pathway or alternative pathway, so that phenylalanine is converted into phenylpyruvate, which is known as phenylketone. Hence, the condition is called as phenylketonuria because there is increased phenylalanine pyruvate concentration in the urine. Normally, phenylpyruvate, phenylactate, and phenylacetylglutamine are absent in the urine. Her mother also noticed mousy odor of the urine because of the presence of phenylacetate and the other metabolites of phenylalanine, which has entered the minor pathway. Hence, this condition is a phenylketonuria due to or based on the laboratory investigations as well as the clinical manifestations of phenylketonuria. Thank you all for watching this video lecture.